thanks so much. How's the course been? Have you guys been enjoying the course so far? Good. So we're kind of ending the more basic part of the course, and we're really moving to how it applies to human beings. So today and tomorrow, we're going to focus on how you take that information that you learned on Monday, Tuesday, and Wednesday and apply that to practice medicine. So raise your hand if you think you might want to go to medical school one day. Okay, good. I'm just trying to get a sense of who's in the audience. And raise your hand if you're a graduate student. Some graduate students in here? Okay, fantastic. Good. And most of you are undergrads, that's my understanding, right? Okay. So, you know, I want to try to make this as interactive as possible. And so please don't hesitate to jump in if you have any questions or anything like that. So, for a long time in medicine, probably for over 100 years, we've known that some cancer runs in families. So raise your hand if you have someone in your family that has had cancer. Okay, so we can see right now, right? So there are, you know, people had a sense that, ooh, there's a lot of cancer in my family. There's a difference between having someone in your family who has cancer and really having a strong genetic drive for cancer, okay? So that's important. So I don't want that, you know, sometimes when you go to medical school, it's like whatever lecture you have, you go home and you're like, oh my gosh, I have that disease, okay? So I don't want you to go home thinking, oh my gosh, I'm going to get cancer. So, but we're going to talk about that today, okay? And so this is this picture was a really interesting story about a family that had a lot of cancer. And this was the start of kind of putting this whole thing together. So Dr. Broadus is in the corner. So he's a pathologist who's a specialist in Lynch syndrome. He's going to talk this afternoon with Dr. Cruz, who is a gastroenterologist in Puerto Rico, and they're going to talk about Lynch syndrome and some hereditary GI cancers. But let me tell you the story here. It's a very interesting story. So there was a pathologist who worked at the University of Michigan, and he had a seamstress, and that seamstress was always depressed. And so he started to talk to her and say, well, why are you depressed? And she said, well, so many people in my family die of cancer. And so he started to write down all of her family tree. And they did, in fact, have a lot of cancer. And so he called this family Family G. And it turns out that he followed this family over many, many years, over decades. And then another doctor named Henry Lynch, who also became very interested in these families that have a lot of cancer, continued to follow it. And so, you know, over 80 years, this family has been followed, where you can see all the people who've developed cancer. And what happened was about in the mid-1990s, so now about almost 20 years ago, they actually figured out the specific gene mistake that was responsible for this family. So, you know, hereditary cancer has gone from, you know, looking at families and identifying families that have a lot of cancer to actually being very specific about the gene that causes that mistake. And then we've gone even farther by taking, you know, some of the daughters and sons and being able to test them for that very specific mistake. And then let's say that, you know, that was you, and you knew that you had an 80% chance of developing cancer. That's a very strong thing. So and we would institute some prevention and screening at a much younger age than someone else. So the field, you know, from a human standpoint, has really evolved from an observation, okay, to being able to specifically identify the gene, to being able to specifically identify the mistake in the gene, to being able to test someone who doesn't have cancer and potentially to save their life. So it's a really neat kind of story overall. And then this is the other syndrome that I'm going to talk about this morning, and this was the cover of Newsweek in December of 1993. And so same thing, you know, raise your hand if you have breast cancer in your family. Okay, so breast cancer is pretty common, right? But there are some families, and probably not your family, so I don't want you to worry, that have a lot of breast cancer, okay? And they actually identified the gene that was responsible for these families that have a lot of breast cancer. And that this was the cover. And you can see what the cover says. It says that this woman here, Jo Cunningham, 59, had breast cancer, okay, and it said her daughter had a preventive mastectomy. Okay, so it just shows 3 generations of women and kind of how that can affect it. So the second hour, I'm going to be talking about this particular syndrome that involves breast cancer and ovarian cancer. So again, this is a very, a lot of what you did was fairly theoretic, right, in the first 3 days, but this is going to really bring it home in terms of how we use that. Okay, so I want to talk about the difference between sporadic cancer and hereditary cancer. And so this is to reassure you that most of you who raised your hand when I said, do you have someone in your family that has cancer, most of your families, okay, have sporadic cancer, okay, and it's unlikely that many of you have this hereditary cancer. So basically, if you look at breast cancer, ovarian cancer, colon cancer, the solid tumors, we call them the solid tumors, about 5 to 10% of those individuals who have those cancers got it because they've inherited something, a gene mistake from their dad or their mom, okay? So about, if you take breast cancer or ovarian cancer, about 5 to 10% have an inherited cause, okay? 90% is bad, what I call bad luck. Okay, so we don't really know. It's probably a combination of things. Maybe there's a little bit of genetics involved in that. Maybe there's too much fat in your diet. Maybe it's your cell phone. We don't really know what it is. It's probably a combination of factors. But that's what we call sporadic cancer. Okay, and about 5 to 10%. It is because it's likely because you've inherited a mistake in a gene that puts you at increased risk. And if you look at these pedigrees, so we're going to talk a lot today and tomorrow about pedigrees, okay? And so how many of you have drawn a pedigree or know what a pedigree is? Okay, good. That's great. Okay, so let's start from the basics. So remember, circles are women, right? Squares are men. That means they're married and they had a child, okay? And so this woman married this man, and they had 4 children, and of their 4 children, this person had breast cancer. So usually we either, when we do these, and we may actually do that this morning, is have you all draw out your pedigrees. We usually will color in if they've had cancer, okay? And so this person had breast cancer at the age of 60. So what are some things that we want to notice about here? Well, one of the things is there's not a lot of cancer, right? There's only 1 breast cancer. The other thing is that 60, breast cancer is so common, right? So the incidence of breast cancer is, is about 11%, so 1 in 8. So this is not likely, because it's an older age, we are less kind of concerned about that. But then let's look at this one, because this is a very different. So again, here, breast cancer at a young age. Usually when we're thinking about breast cancer, because it's so common, breast cancer over 50 is less worrisome to me than breast cancer in the 30s or 40s, okay? So anything under 50 is going to be a little bit more worrisome. But look how many, breast here, breast here, breast here, and ovarian here. So what I'm going to kind of teach you is that there are syndromes where there's cancers that are very characteristic of a particular syndrome. So this morning we're going to talk about BRCA, which is a syndrome where breast and ovarian cancer tend to happen a lot in families. And then this afternoon we're going to talk about Lynch syndrome, and in that syndrome there's a lot of colon and uterine cancer. And so when you look at this family, you can see, wow, there's a fair number of breast cancers and ovarian cancers as well. So when you're taking a patient's family tree and you see something like that, the little red flags are starting to go off in your head that this is more likely to be hereditary than sporadic. So the other thing I want to talk about, and I don't know if I have a slide, but I think it's really important because you've been listening to genetics for a whole week, is the difference between what germline genes are and tumor genes are. So does anyone know the difference? Does anyone want to tell me what the difference between germline, what your germline DNA is versus tumor DNA? So let me just kind of talk through that. So you've been, earlier in the week, they've talked to you about P53, right? And Dr. Strong and Dr. Lozano talked about P53. But it's important to distinguish in your head a mutation that occurs in the tumor, okay, versus a mutation that occurs in the germline, okay? Your germline is every cell in your body, okay? So all of your cells in your body, okay, have a complement of DNA, okay? And the inherited mutations that we talk about for inherited cancer has to do with your germline DNA. So that when we start talking about genetic testing, and we're going to talk about genetic testing this morning, you basically just give a blood sample. You could give a blood sample. Sometimes they take actually some a buccal swab, so you can just actually smear the inside of your mouth. It can be a skin punch biopsy. It can be anywhere, okay? Because when we're talking about germline DNA, it's in every cell of your body, okay? When they talk about P53 tumor mutations, or yesterday when Dr. Heffernan was talking about brain tumors and EGFR mutations, those aren't in every cell of your body. Those are only in your tumor, okay? So it's important to distinguish between germline DNA mistakes or mutations and tumor DNA mutations. Okay, so moving on. So this is kind of what I was telling you about before. About 10%, okay, of solid tumors is cancer. So why is this important? Because I see a lot of patients with ovarian cancer or breast cancer, and they come to me and they all think that they got it from their parents, okay? And so I reassure them that 90%, okay, of cancers is not hereditary, okay? So the vast majority of the people in your family who got cancer, it's not because of this. And so what are some of the ones that we know, right? We know lung cancer. What's lung cancer associated with? Right, smoking, okay? So that's a very obvious one. I saw some of you had the HPV bags, right? Did you go to that HPV conference? I heard that was a really good conference. But you know, like cervix cancer, right? Head and neck cancers, anal cancers, a lot of those cancers are HPV viral related, right? Sexually transmitted, okay? So those are not gonna be inherited cancers. So about 10% of our solid tumors are inherited. Okay, so have you heard about the two-hit hypothesis? Did someone earlier in the week talk about the two-hit hypothesis? Okay, so basically, this is an important concept. So you have in your body 2 copies of every gene, okay? So when we talk about some of the genes that we're gonna talk about today, BRCA or Lynch syndrome genes, you've got 2 good copies. You have one from your dad and one from your mom, okay? And the reason cancer is, we say that cancer is a disease of aging, okay? So it's rare that cancer develops in younger people. And why is that? It's because you've got 2 good copies of every gene. And so cancer develops when there is a specific set of genes where they're no longer functional, okay? And in order for them to be no longer functional, you've got 2 of them. So you might knock out one because you were on the cell phone for too long, and I'm just joking about that, so don't take me seriously. But you still have another one that works really, really well, right? Okay, so it takes knocking out both of them, okay, of a very important gene, of some kind of tumor suppressor gene, before you develop cancer, okay? But if you've inherited from either your dad, and this can come from either side, so even the breast cancer gene, it's a mistake to think it just can come from your mom's side. It can come from your dad's side too. So let's say you're born with a mistake in the BRCA gene, okay? They tend to occur, remember that pedigree I showed you, they tend to occur at an earlier age because you only need to have one other hit before you develop cancer, Okay, so that's what the two-hit hypothesis is that you've got to get rid of both of your good functioning genes, okay, in order for there to be development of cancer. So if you've inherited one already, okay, so one of the hallmarks of hereditary cancer families is a younger age of onset, okay, and that's because of this two-hit hypothesis. Does anyone have any questions about that? Go ahead.
And they have the BRCA gene, and they want a preventive mastectomy or hysterectomy. Is that viable? What advice would you give them?
Yeah.
Because I saw it at the cover of Newsweek that the daughter got a preventive,
right,
but maybe she, in her life, she probably won't develop
right,
ovarian or breast cancer.
Right.
So what advice would you give them?
Right. That's a great question, and we're going to spend a whole hour talking about that. So that'll be kind of our next lecture after that. But the bottom line that I want to say is that you know, we talk about like the power of molecular medicine, and you've heard 3 days of like, wow, we can, you know, we can sequence the entire genome of each person. We can sequence the entire genome of the tumor. And so what I want to talk about today and tomorrow is how that really affects that person that you were talking about. You know, so why is it that I'm going to explain to you that the woman, the grandmother who had cancer, what we were able to do for her is we were able to find the specific mistake in her gene that caused her breast cancer. Okay, and I want to explain to you that one gene is like a 600-page novel. Okay, one gene is really, really big if you kind of add up all the nucleotides, and so to find the mistake, it's like proofreading that novel. It's expensive. One gene, I'm not talking about your whole genome, okay, which is like a huge library. I'm talking about one gene. But we're able to find that spelling mistake. And when you find that spelling mistake, then for her children, okay, you only have to look for the spelling mistake. Okay, you don't have to read the whole novel anymore. So that's why when you take the grandmother, it's very expensive because you've got to go through every single thing. Once you find the mistake, for the daughter, it's only about $400. It's at $4,000 to do the whole sequencing. But for the daughter, it's just one. And if the daughter has that mistake, then she's about at 80% risk for breast cancer. So then I would say to all of you in this room, if you're at 80% risk for breast cancer, what would you do? And that's the question that you're asking, because it sounds so dramatic, right? It sounds so dramatic to say, wow, really to have, but if you had seen all of your relatives, right, if you had that family and you had all of that breast cancer and your mother had died of breast cancer, you approach things in a very different way. So it's a great question, and we'll definitely go through it. Okay, this is kind of that same concept, right, about hereditary cancer and sporadic cancer. So I made it pretty simple with the two-hit hypothesis, meaning just saying that if you lost, you know, one, if you lost both, if you had a mistake in both of your alleles of a single gene, you develop cancer. It's not that complicated, that easy. But this is kind of the general idea here. So the bottom is sporadic cancer, and the top is hereditary cancer. And so basically, cancer develops when you have multiple genes that develop here. And what we're saying is that when you have sporadic cancer, you know, you end up having all of, like, let's say it's 6 different genes that have to be mutated before you get the cancer. And this is just showing that when you are born with one, okay, you've already got 1 out of the 6, and so this can all happen, and cancer just happens at an earlier age. So this is just the more complicated version of that last slide to show that one of the hallmarks of inherited cancer is younger age of onset. Okay, so why is this so important, okay, when we take care of patients? This is a big one, okay. It helps people understand why they got cancer. That's one of the most important things people say to me is why, you know, you're 42 and you develop breast cancer. You know, why did I get cancer? Sometimes when you disclose to them, when you identify what the mistake was, it helps them relax a little bit. Okay, I know why my family, I know why I got cancer. The other thing that I want to stress today, and then this will be a theme for today and tomorrow, is that you must start the testing on the person with cancer, okay? So that's why I'm a cancer doctor, right? We really want to focus it on someone who has cancer first, and that's that whole concept I was just talking about the spelling mistake, okay? Because if I take her daughter and I do that and I spend $4,000 and I check for the spelling mistake and I don't have it, so it's a negative, I don't know if she doesn't have it because her mother didn't have it either, or it's just that she doesn't have it. So it helps us define what a true negative is, okay? If the mother had the spelling mistake and the daughter has a 50-50 chance and doesn't have the spelling mistake, we can tell her absolutely, okay, her risk for breast cancer is not 0%, but it's about 11%. So she goes back to, instead of 80%, it's 11%, okay? So we really want to stress the concept that we want to start the genetic testing on someone who has cancer. What are the other implications? You can prevent a second cancer. So I have some patients, and think about how terrible this is. We have some patients at MD Anderson who developed breast cancer in their 30s and 40s. And this was before the time that we knew about these genes. And so what happened was, since we didn't know about the genes, we cured them. We did a great job. We cured them of their breast cancer when they were 30. But what happens is, when they were 50, they developed ovarian cancer. And ovarian cancer is a very lethal cancer. So they ended up dying of ovarian cancer. We feel terrible about that, okay? And if we had known that about the genes, we would have said, let's get the gene test. This is what we do now anyway, in a 30-year-old person with breast cancer. We do the gene test, and if they're positive, we say, let's get your ovaries out, okay? And so then we prevent that ovarian cancer. And it's the same thing this afternoon. Dr. Broaddus is going to talk about Lynch syndrome. The worst thing is that we can cure someone of their endometrial cancer and then have them die of a colon cancer. Okay, so these people are also at risk for developing second cancer, so we want to prevent that. And then more recently, we know that people who have cancers and who have the gene, they actually act differently than the 90% of people who have cancers who don't have the gene. So it's a very interesting area of research. So for some reason, if we look at ovarian cancer, oops, oh, I just broke the pointer. All right, sorry about that. Well, I have to do without it. With ovarian cancer, we know that if you have the BRCA gene, okay, that you will live longer, okay? When I see somebody with ovarian cancer who's been cured, who's lived more than 5 years, the first thing I think about is, ooh, I wonder if they have a BRCA gene, okay? Because for some reason, their tumor is more sensitive to chemotherapy. And so they just do better. And it's just we're trying to figure out why that is and to take advantage of that. And then even treatments, they're developing drugs that are particularly good if you have the gene. So for both breast and ovarian cancer, they're called PARP inhibitors, and the tumors are particularly susceptible if you have a tumor that's associated with BRCA. So there's a lot more implications for patients than there used to be. Okay, so we talked about implications for the patient, but what about the implications for the family, right? Because there's implications for the family as well. Okay, so remember we talked about genetic testing. So if you were part of that original family, okay, let's go back to this. If you were this daughter, what would you be thinking about? You'd be saying, I'm doomed, right? Because you've got these relatives with cancer, and you think, I'm doomed. But this is the power of genetic testing. The power of genetic testing is, if we've identified the gene here, and these two people have it, remember, each child has a 50-50 chance of getting it. So we can actually tell very precisely, this person, you do not have it. That's a very powerful thing to say to somebody who comes from a family, where there's cancer everywhere. And so if we can't find a mutation, okay, so we're not perfect, right? We haven't been able to find the mutations for every single syndrome. So when we can't find a mutation, we have to tell every daughter, you have to kind of be on the lookout. and that you might have a really high chance of breast cancer. That drives people crazy, right? Should I have my ovaries out? Should I not? Should I have my breasts removed? Should I not? Okay, when you can say very precisely, you definitely have an 80% chance of breast cancer, you can make decisions based on that. Not that it's so easy, it's still pretty hard. But when you can't be precise with your risk estimate, that's actually an even harder thing to do. Okay, how do we manage these high-risk women? It's really challenging, okay? It's really challenging to take someone in front of you who's 22, who has a lot of breast cancer in their family, and who's on the internet reading about this, to talk to them and to reassure you, you can have a normal life. A lot of what I do is actually reassure women, like, you know what, you can have your kids. It's okay that you're 30 and you're not married, you know. We'll watch you, and then, you know, have your kids, and then when you're in your 40s, we'll think about having your ovaries out. Okay, there's a lot of anxiety, even amongst doctors who are taking care of these people. So a lot of people come to me and say, you know, my doctor told me I have to have my ovaries out, but I haven't had kids yet, I'm not even married yet, you know. So there's a lot of interesting psychological challenges in this population. What I wanted to say is that we're not that sophisticated yet. So we've got some good screening, like colon cancer screening is pretty good. But you'll hear this afternoon, like, would you want to have a colonoscopy every year? That's kind of a bummer, right? Our screening for breasts, for mammograms and MRIs is pretty good. For ovary, not so good. We don't have any really good screening for ovary. Prevention, we'll talk about a little bit about prevention, but really right now for the management of high-risk individuals, prophylactic surgery is really the most effective thing, okay? So that's why we'll talk about removing ovaries, removing breasts and things like that. As we get better with this, then we won't have to do this as much, okay? But for the time being, you know, we're still in the pretty early stages, and we know that this works, okay? These things, we're still working on it. Okay, so the next couple slides, we're going to talk about how do we identify who's part of the 10% of the pie and who's part of the 90% of pie. So we always start with family history, okay? So if I had a breast cancer patient or an ovarian cancer patient in front of me, okay, and what you do is you obviously are going to focus on how to manage their cancer, but part of the history and physical is you take their family history, okay? And so what are the kind of things that I think about? So, you know, you're busy, you're focused on their cancer. Someone just came to you and they have cancer, and you're focused on that. But we can ask a pretty fast family history. You know, do you have any relatives that have had cancer? And most people say, oh yeah, I think I had someone in my family with breast cancer. So the important things that I want to ask are, how old were they, okay? Because a lot of people will have, oh yeah, I had a lot of female family members who are in their 70s and 80s with breast cancer. So I worry less about that. So I want to know what kind of cancer, and I want to know at what age. The other really important red flag is there someone in your family that has had 2 cancers, okay? So is there someone in your family that had breast cancer and ovarian cancer, okay? Or colon cancer and uterine cancer? That's one of the biggest red flags for us, okay? Because it's unusual, right? It's unusual for someone to have 2 cancers. So we're not talking about metastasis, right? Sometimes someone will have breast cancer and it goes to their spine, or breast cancer and it goes to their liver. I'm not talking about that. I'm talking about really 2 separate cancers. So if someone in your family has had 2 separate cancers, that's a big red flag for potentially an inherited cancer. And then we're gonna move to talking about genetic testing. Okay, so let's talk about family history. So we're gonna spend some time talking, and now that I've totally ruined this this poor. Okay, so the key thing about cancer genetics is that it's autosomal dominant. So how many of you have taken a genetics class? Have you taken basic? Okay, good. So you know about autosomal recessive, autosomal dominant. So cancer genetics, the majority of cancer genetics are autosomal dominant. Okay, so when you see autosomal dominant, it means that you'll see a lot of cancer in the family. Okay, so one thing is that each child, okay, has a 50-50 chance of inheriting the mutation. okay? There's no true skipped generations, okay? And this is an important thing, is that it's equally transmitted by men and women. So even the breast cancer gene, even BRCA, it can go through the dad's side. And we see this mistake a lot, where a lot of doctors even make this mistake. You know, they say, oh, thanks. Oh, did you fix it? Oh, awesome. All right, extra points for him. Okay, so so we'll often, so men will not necessarily get the breast cancer. So they'll have the gene mistake, but they won't have, they obviously don't have ovaries, and they don't really get breast cancer so frequently. Sometimes they do. So what will happen is we'll see something like this, and sometimes even doctors will make the mistake, and they'll say, oh, you know, did your grandmother have breast cancer? And they'll say no. And they'll say, oh, okay, well then I think you're okay. But what they didn't realize is that it's through the father, okay? And so you always have to ask about aunts on the dad's side. So it can equally be transmitted by men and women. When we say no skipped generations, that means that, let's say, well, this is not the best pedigree here, but you know, sometimes it looks like it skipped a generation because it only hit the men, and the men didn't get cancer. Okay, so really, if you did the genetic testing on every single person in the family, you would see that there are men that have it, but it appears that there's no cancer in that generation because the men didn't manifest it. Okay, so even though it's autosomal dominant, okay, it's incompletely penetrant. Okay, that means that there will be people in the family, okay, who have the gene, but for some reason did not get cancer. So that's an important point, because sometimes I'll see a daughter, okay, who has ovarian cancer, and their mother is 70 and alive and fine. But it turns out that she had her ovaries out because in the 50s everyone was having a hysterectomy, okay? And so maybe, and that's why she didn't get it. And why didn't she get breast cancer? You know, who knows? That's the magic question. There are some people who even have the gene but don't develop cancer. So it's not 100% penetrant. So that's why I was saying before, it may appear to skip generations, but it doesn't. And individuals, they inherit the mistake in the gene, but they don't actually inherit cancer, okay? So they're at high risk for cancer, but it's not 100%. Okay. Let's just talk through this pedigree, because I think it's interesting pedigree. So this grandmother had cancer, okay? And this daughter had cancer here, okay? And what it looks like here is that there's cancer here, but this person did not have cancer, okay? So this could be one of the things where I was talking about before, like let's say these are ovarian cancer cases, okay? Although it can't be ovary because of the male, but let's just kind of ignore this. And there's, you know, breast or ovary here, and they say, wow, this mother, why didn't she, you know, she's 70 years old, how come she didn't get cancer? Well, it may be that she had her ovaries out in her 30s, and when you remove your ovaries, it decreases your risk for ovarian cancer, but it actually decreases your risk for breast cancer too. Okay, so our point is that sometimes when you draw out your pedigree, it looks like you didn't have, there's a generation that it skips, but if you actually did the gene testing, you would see that it doesn't skip a generation. Okay, so this is a classic family of BRCA. So we can start here, and let's say this is my patient, okay, or let's say this is my patient. Ovarian cancer. Okay, diagnosed at 59, not so young, okay, and she ends up dying 3 years later, okay, and her niece developed breast cancer at 36. And this is a big red flag for us, right, because 36 in breast cancer, that's unusual, okay, most people with breast cancer are older in age. So this person is alive, this person's dead. We can't do the genetic testing on this person, but we can on this person. So we do the genetic testing, it costs about $4,000. We identify the mistake, okay, here that this person has, and we say, if I look at this pedigree, it looks like this person, you know, it looks like there's a lot of breast and ovarian cancer, but it had to have come through the dad's side. So what we will do next is, because this person's died, we'll say, well, it had to come from the mother or the father, and let's solve it. A lot of this is like mystery, it's like sleuthing, right? So let's go ahead and test the father. So we've tested this person, we've found this specific mistake, and then we can actually test the dad and the mom, okay, because it's about $400 to test. So it turns out that the dad, who has no cancer, is the carrier, okay, and that will allow us to test his sisters. Okay, his sisters may both be negative. Remember, each person has a 50-50 chance. Okay, they may be negative, in fact. Okay, and then we can go further up. This person's still alive, and we say, wow, you know, she's still alive. Let's test her, because this person had to have gotten it from somewhere. Did he get it from the mom, or did he get it from the dad? And then we test, and it turns out that the mom does in fact have it, but maybe for some reason, you know, who knows, maybe had a great lifestyle and never developed cancer. Let's say didn't even have her ovaries out, is 92 years old, and that's where it's coming from. So it's really, from my standpoint, it's fun, because you can take a family and you can kind of, you know, solve the mystery within the family. And it's really nice when it actually works, right? Because one time we did a family, we actually went, and this was a Lynch syndrome family, and the grandmother, the aunts, who were older, you know, they all had cancer, and we said we want to find the gene in your family, so we took the blood from the 2 aunts that had cancer, and then there were like eight grandchildren, all in their 20s. And the aunt said, we just want to pay for everybody to have the testing. And when we kind of put it all out, and I don't know if Russell, I don't know if you have their pedigree, the big family pedigree, I think he's going to show it this afternoon, it's about 50-50. So that was great, because when it works out the way it's supposed to work, it's really nice. So that's one of the really satisfying things about cancer genetics. So you use your pedigree, okay, to help you decide about risk to patient and family members, okay? One of our goals for the next 2 days is to have one of you go into cancer genetics. So if one of you goes into cancer genetics, we'll be so happy. And so Molly Daniels, who's our genetic counselor, is going to be giving a lecture tomorrow morning, and she's going to talk about what she does, okay? So we partner, okay, Dr. Broaddus and I and Molly partner to see these patients, and they have a great job. So they sit down with the families, and they draw out these pedigrees, and they talk about, looking at your pedigree, let's talk about whether, you know, you have a family that's concerning. They talk about genetic testing, they talk about the risks of genetic testing, the benefits, and then they refer people for screening, prevention, and support, and they participate in research studies. So we start with the pedigree, and then we go on. I want to talk about family history. It's fairly time-consuming to come up with a 3-generation pedigree, okay? So I think I want to spend just about 15 minutes or maybe even less. So on your paper, everybody write their pedigree. I want you to draw your pedigree. So what I want you to do is I want to start you with yourself. I don't have a board to write on. So start with yourself, okay? So either a square or a circle, okay? And then go up, okay? And draw your parents and draw your siblings, okay? And let's see, I wish I had something to draw on, but I don't have anything to draw on. Just get started and I'll walk around and help you. And so what I want to do is, and then when you have your parents, draw out how many siblings they have, okay, and your grandparents. So I want you to draw out a 3-generation pedigree. And if someone has cancer, circle in, okay, and then write down what that cancer is. Okay, so let's kind of come up with some themes. So, what are some observations you have after putting it all on a piece of paper? You're scared. Okay, I'll take private consults after when we take a break. So, okay, but who's reassured? Who thought, oh, I have a lot of cancer, but then when you draw it out, it doesn't look that bad based on age? Okay, yeah, tell me about your family.
So I have both my grandparents got prostate cancers from both sides.
Uh-huh.
They didn't die of that, but they got it from, and one of my uncles has colon cancer.
What age were the prostate and colon cancers?
So both the prostate cancers were after 60 years,
uh-huh.
and colon cancer was in 50.
Okay, okay. So maybe a little bit more worried about the colon cancer, but I know I looked at quite a few people and you had prostate cancer, you know, in the 70s and breast cancer in the 70s. It's good to see that on paper because then you say, you know what, that's normal, okay? Not normal, I mean, it's unfortunate, but it's common, okay? So I don't worry, you don't worry that, oh, I'm part of this inherited, because sometimes you're like, wow, I have a lot of cancer in my family, but then when you draw it on a piece of paper, you're like, you know, older onset. So that's what the genetic counselors do, okay? They sit down with patients and they draw it out. Here's another observation I noticed from some of you. You don't actually know the details, okay? And we see that all the time. And so then we start to write it down and they're like, ooh, I had that one uncle, but was it a bone cancer or was it a liver cancer? You know, and then you end up having to text your mother, right? When I text my mother, you know, oh, you know, and then your mother says, oh, I've got to ask your aunt because, you know, I was the youngest one in my family and I didn't know that. So even though when we meet with people, we will send them home and we'll say, go find out about your family, okay? Because sometimes people just don't know their family history that much. What are some other observations? Anyone else? Go ahead.
I'm surprised that my grandmother got breast cancer when she was 35.
Okay.
And I have 7 aunts, and none of them has breast cancer.
Perfect observation. So when you hear about a 35-year-old, okay, who has cancer, you worry about that. But you, people who have big families should be happy they have big families because that will reassure you. If you didn't have all of those aunts, okay, then you'd be much, much more worried. So we're going to talk about limited family structure, okay? As families get smaller and smaller, it gets harder to interpret it, okay? When you've got lots of aunts, it really, or lots of cousins, it's really helpful in terms of reassuring it. And so I think Molly's going to talk about models. There are computer models that you can get online and put in people's family history. It helps the genetic counselor. So the genetic counselor will start with a pedigree, and then they'll use computer models. And the computer models, if there's a small family structure, it'll weight it more than if you have 6 female relatives, none of whom have cancer. That'll decrease your risk. So that's a really, really important point in genetics. Okay. Anyone else? Anyone else? Go ahead.
Well, I didn't know how to classify. My mother had a tumor, but it was removed. But I didn't know how to put it in the pedigree.
Okay.
It was benign.
It was benign. Okay, great point. Here's the other point is benign tumors, we don't necessarily, you know, worry so much. There are some benign tumors that are rare that will come up, but a genetic counselor will go through that and they'll say, what kind was it? Was it an unusual histology? And sometimes what we have you do is go get that person's pathology report. Okay, sometimes we'll go so far because ovarian cancer in particular is hard because people will have, you know, they'll say, oh, my grandmother had stomach cancer, but they're not really sure if it was stomach cancer or ovarian cancer. And then some people will have ovarian cancer, but it was actually a cervix cancer, you know. So oftentimes we'll say to people, go back to the hospital, even though it was 30 years ago, and get the pathology report. Okay, so again, it's that thing about you've got to really, you know, investigate your family. So any other observations before we move on? No? Okay. So it's helpful. It's helpful both ways. You know, when you write it down, it can be very reassuring, right? But sometimes you can put it down, you're like, oh my gosh, you know, this is obvious that look at all the 30-year-olds with cancer, look at all this cancer in my family. So it's really helpful to put it on paper to get a better sense of things. Okay, so we're going to talk about a little bit more. Okay, so what we do is we do the point of this is that things change over time. So if you meet with a genetic counselor, that's one point in time. And you may have a lot of cousins all in their 30s. And so they haven't had cancer yet. But if you ask them 5 years later, you might start to see a lot of cancers. So, you know, the first visit, we say, does anyone in your family, parents, grandparents, siblings, aunts, uncles, or cousins have breast, ovary, uterine, or colon cancer? And then subsequently, when we see them, we say, you know, has anyone recently been diagnosed with these cancers? So the idea is that things change over time. This is the thing about, we were talking about validating things, right? Verifying your family history. So this is what they told the genetic counselor on the first go-round. My grandmother had stomach cancer, my sister had bone cancer, my brother had prostate cancer. And then when we asked to get the pathology reports, it turned out that the mother had ovarian cancer, and the sister had breast cancer that went to the bone, but it started as a breast cancer. So if you were looking at this, you would say, I hope all of you would say, oh, you know, the red flags are going off. I think this family has the gene. I think this patient needs to be worried. Whereas if you saw this, you'd say, I'm not so concerned. Okay, so that's where getting that, really hunting down the pathology reports makes a big difference. Okay, and this is that concept that I was talking about, so that, you know, this person may be my patient who comes in with colon cancer, and they have a small family and no cancer, and then 2 years later, you know, their daughter develops endometrial cancer at a young age. Okay, then I'm much, much more concerned, and polyps at 48. Okay. Okay, so this is the same thing that we talked about before. Okay, what are the indicators of a possible hereditary cancer syndrome? Early age at diagnosis, cancer in 2 or more relatives on the same side of the family. Okay, a combination of cancers indicative of a specific syndrome. So we're going to be focusing on BRCA, which is the breast and ovarian syndrome, and Lynch syndrome, which is the colon and uterine syndrome. Multiple rare cancers. Dr. Strong talked to you about P53, right? Inherited P53, and they develop all sorts of weird sarcomas at a young age. Breast cancer as well, and then multiple primary tumors, right? Does one person in your family have both breast and ovarian, or both colon and uterine? Okay, there's, not showing up very well, but there's this rule that I really like. It's called the 3-2-1 rule, okay? And it means that 3 people in your family, okay, it has to be on the same side, right? You don't add your mom's side and your dad's side, so it either has to be on your dad's side or your mom's side. So 3 people in one lineage that have cancer, okay, 2 or more generations, and 1 person under the age of 50, okay? That's just a general rule for thinking about inherited cancers, 3-2-1, okay? It's kind of a nice thing for us to teach doctors to think about. Okay, so how do we get into trouble? Okay, we get into trouble when we have limitations, okay? 1, small families. Okay, we're seeing more and more small. Anyone here have a small family? Okay, so, you know, it's harder, right? It's harder for you to know because there's not enough people to see cancer. Another one is not enough female relatives. Okay, not his problem in the back, but I know some of you had not enough female relatives, okay? Adoption, okay? What happens if you're adopted? I had a really interesting patient who was from Florida, and she was, I think, 45, had ovarian cancer. She was adopted, and but she had the gene. We diagnosed that she had the gene, and so she actually went back, found out who her adopted relatives were. Some of them were in England, went so far as to go to England to disclose the information, and had her relatives tested. Because once you have this information, it's very powerful information, and you want to be able to make sure your other family members can take advantage of it. The other thing that we see sometimes is non-paternity. So if you identify someone who has the gene, and then you test the father and you test the mother, and neither of them have the gene, what does that mean? That means probably it's not that dad is not really the dad. So it's it can be a little tricky in that circumstance, but we see it. Okay, we see that happen. Okay. So this is something else that can happen, and I don't like this word phenocopy, but I'll explain to you what it means. So when you look at this whole family structure, you think, wow, that is a lot of breast cancer. And so the first thing you say there's got to be a mistake in there somewhere. So in this family, we tested this person who was alive, and we found this mistake. This is a mistake in the BRCA2 gene. It's at the 6174 spot, okay, and there's a deletion of the nucleotide T, okay? And we tested this person, and let's say theoretically we were able to test these people before they died, and they all have that. Well, this is a young person who has breast cancer at the age of 36, and she's part of this family, okay? And so we test her, and she does not carry it, okay? We see this sometimes, and what it means is that, especially with breast cancer is fairly common. And sometimes this is a rare bad luck phenomenon where she didn't actually inherit her family's mistake, but she still got breast cancer, okay? And so sometimes that happens and you're like, how did that happen? And it's very confusing because what we say to her is, actually you're not at high risk for ovarian cancer because you don't have this mutation. But she's like, but then how can it be because I'm related to all these people? But from a genetic standpoint, what this means is random things can happen, okay? And that this person had a 50-50 chance, right? This mother had a 50-50 chance of having this same thing, and let's say didn't get it, and then these are her children and her grandchild, and even though there's a lot of cancer in the family attributable to this mutation, this branch of the family does not have the mutation, but you still can happen. So that's why even all of these relatives who test negative, we never say your risk for breast cancer is 0. We say your risk for breast cancer is the population risk, which is 11%. Go ahead.
So if you got a 36-year-old patient and you did the whole mutation analysis and they had the BRCA mutation, how did you find out that the other?
Yeah, you had to have tested this person.
Right.
If this person was dead, then you wouldn't be able to solve it.
Then you go back and you do the whole sequencing again, though.
Yeah.
Because if you only look at
Yes,
the patient, you can
correct. Correct. So what we do for this person, let's say we knew this, the way we start is we want to start cheap, okay? So we just look for this mutation, and that's negative, and we're like, okay, that's a little confusing. So then we go back and we test the whole gene, because we say, well, maybe from your dad's side, from your mom's side, right? So this is coming through her dad's side of the family. Maybe the mom's side of the family, where we don't have the pedigree, it's a different gene. So then we test the whole thing, and it's still negative. And that's when we call it a phenocopy. Okay. Okay, so if you look at the most common cancers in women, okay, I was going to ask you this, but everyone knows breast cancer is the most common cancer in women, right, in Puerto Rico and in the US. Lung cancer is next, colorectal cancer is next, and then uterus. This is a number of cases. And this is what % is caused by kind of an inherited thing. So breast, it's about 7 to 10%. Lung, we know what's lung cancer caused by smoking, right? So none of these are really caused by inherited cancers. About 5% of colon, uterine, and ovaries about actually 10 to 15%. So these are all the number of inherited cancer cases. And one could argue that many of these are preventable, okay? So my goal as a doctor is to identify the individuals who have the gene and to really try to do early screening. They may not be preventable, but I'd like to say that people wouldn't die from cancer. So I'll be successful in my lifetime if you can take the family tree that we've seen and in these families that have mutations, and instead of having tons of cancer, if we have people who have the mutation, okay, but don't die of cancer, okay, they still may get it but hopefully the screening is catching it early so they don't die from it, and that to me would be a success. But my point here is that there's a lot of cancers that are potentially we're able to identify those individuals as being at high risk. Okay, what are the syndromes that are out there that we know of? So remember how the syndromes were initially found? Okay, the syndromes were found because doctors kind of noticed families that had a lot of cancer. So that's why they're called syndromes. Okay, they're not called diseases, they're called syndromes because it's just something that people noticed. So remember, we're going to talk about hereditary breast ovarian cancer syndrome, and we know the gene for that. We're going to talk about Lynch syndrome, which is also called hereditary non-polyposis colorectal cancer. These families get breast and ovarian cancer. These families get a lot of colon and uterine cancer. There's a syndrome called Cowden syndrome, where they get a lot of breast and uterine cancer. This afternoon, you're going to hear about FAP, which is colon cancer. You heard about Li-Fraumeni, right? P53, remember? P53 is a common tumor suppressor that's altered in tumors, okay, that's called somatic mutations, but there are some families, talk about bad luck, that have mutations in P53, and they have Li-Fraumeni syndrome, and they've got lots of multiple cancers. And then there's one called VHL, and that has a lot of renal cell cancers. And the advance in the last 20 years is that we actually know what gene it is. So that's kind of a cool thing, right? We've gone from just knowing the families to actually being specific about which gene. So BRCA1 and BRCA2 for this, MLH1, MSH2, MSH6 for this syndrome, P10 for Cowden syndrome, FAP, APC gene, Lee-Fermini, P53, and VHL, the VHL gene. So it's neat that we've been able to kind of go from not just identifying families, but actually finding the gene. Okay, so cancer predisposition testing. Okay, who should get tested? Okay, so there's a controversy. You may have heard about, there's a controversy in terms of genetics. If you can't do anything about it, would you want to know? Okay, if you were going to get early onset dementia, okay, or early onset cancer, and you couldn't do anything about it, would you want to know? Okay, and so our society says that genetic testing, okay, or cancer should be offered only when, okay, the individual has personal family history features suggestive of a cancer susceptibility condition. The test can be adequately interpreted, and it's going to influence medical management. Okay, so this is kind of the key thing here, is that it's going to influence medical management. If you can't do anything about it, okay, we don't think that it's worthwhile testing someone. But nowadays, we're much better about medical management, okay? So that's why we're doing a lot more genetic testing. This is a process. It's not like a one-time thing, okay? So we say that it should include assessment of risk, and that's what you all were doing by drawing your pedigrees, education and counseling. It should be connected by someone who has some expertise in cancer genetics, and that's why our genetic counselor is going to come talk to you about what she does. And then it may include genetic testing if desired after appropriate counseling and consent is contained. Okay, I'm going to give you an example of this. Let's say that there's a family in which we know that there's a mutation, okay? Do we test, should I test a 10-year-old? Should I test somebody's daughter? What we say is we say no, because there's never been an example of a 10-year-old or even a 15-year-old developing cancer, okay? So that information, there's no benefit. We don't start screening for breast cancer until probably in the mid-20s, and ovarian cancer in the 30s, okay? So we don't necessarily want to do this, okay, for kids. Another example is, let's say somebody is 23 and it's too early to start screening in them, and they say, you know what, I would rather act as if I have it. So get my screening, okay, but I'm not going to undergo any prophylactic surgery right now, okay? So I don't really, I'd rather act as if I'm positive and just not know, because it's so definitive to know, okay? It's going to worry me more to know than to just act as if I'm going to get screened. So for that person, we may say, you know, that's fine. You know, if you think that you're going to undergo surgery sometime, we don't want someone to have a bilateral mastectomy if they test negative, right? That would be a mistake. We've done that in the past, right, before we had genetic testing. But for some people, they don't want to undergo genetic testing until they're going to make a decision to do something different. Okay. We always talk about what the benefits and the limitations are during our counseling session. Okay, what are the benefits? It's going to be more precisely identifying risk for individuals. It identifies those individuals who should have risk reduction screening. And again, the results can help with uncertainty and anxiety. It can help, but it can make it worse. Okay, it can go both ways. So when the genetic counselor talks to people, they want to talk about all of the options before the testing occurs. Okay. Limitations, we want to talk about limitations. Sometimes there's limitations, okay? Sometimes a negative result can be helpful, sometimes it's less helpful, and we'll talk about that in a few minutes. And then sometimes we get this thing called a variant of unknown significance. So let's talk about that. So sometimes you can have a change in your DNA that goes, so a nucleotide can go from an A to a T, okay? Or a C to an A. Okay, and it actually doesn't change the amino acid, right? If it doesn't change the amino acid, it's unlikely to change. It's unlikely to have an effect at all. Sometimes you lose a nucleotide, and that causes the protein to be much smaller than it would be otherwise. Probably that does have an effect. So when the people who do the mutation testing, they not only have to identify, right, the specific change in the nucleotide, but they also have to be smart enough to know, is this going to affect the function of the protein? Okay? And we do that by saying, does the amino acid change? So sometimes the amino acid doesn't really change that much. Sometimes it changes dramatically so that there's a stop codon, okay? So instead of having a long protein, it stops it, it truncates it, and that's likely to be an important mutation. Okay, so these are the options for your test results. You can be positive, you can be negative for a previously identified mutation in the family. You can have no mutation identified, meaning that we're testing somebody, like let's say all of your relatives are dead who had cancer. So then in that case, we don't have somebody with cancer to test, and we just will test the daughter, and they don't have mutation in the family. It's somewhat reassuring, right? It's still good to be negative as opposed to positive, but we don't know if there is a mutation in the family that caused the cancer. And then the variant, we just talked about variants. And then this is just going through the different things, the test results. And you can look at these. We don't have to go. We just talked about that. So if there's a known mutation in the family, okay, and then the test result is negative, then we say that the risk of cancer is general population risk. We always are careful not to say 0, okay? If you're testing somebody in which there's not a known mutation, okay, then we kind of have to somehow interpret that. It's harder to interpret. And then this is what we were talking about before. So one of the most important things that patients will ask us is, am I going to be discriminated against, okay, if I have a genetic mutation, okay? And so there was a law, it's a federal law that was passed. It's called GINA, G-I-N-A, Genetic Information Non-Discrimination Act. It was passed in 2008, and it basically prohibits your company from from not giving you insurance based on your genetic test results. So that was the fear when all of this started, is that people would lose their health insurance, right? If someone's going to develop a lot of cancer, maybe the health insurance companies would say, ooh, you're going to be too expensive for me to give insurance to. So it prohibits these insurance companies from using the genetic information to determine the eligibility or premiums. They also can't say, ooh, your family has a lot of cancer, we're going to charge you more for insurance. Okay, so this was good. It prohibits employers from saying, we're not going to hire you based on that. Okay, what we talk about this because we always get asked about it, but this is an important concept, is that it does not apply to disability insurance or life insurance. Okay, those two insurances are called luxury insurances. They're not necessity. So basically, often I will have a mother who's in her 50s with ovarian cancer who tests positive. She has a daughter in her 20s, okay, who also tests positive. But before she tests, what we will often say is, if you're going to get life insurance, get it now before we test you. Because the life insurance will say, have you had genetic testing, things like that. And they can deny you, okay? Because life insurance is not covered by any federal laws. So oftentimes we'll say, you don't have to worry about your employer because that's covered by a federal bill. But if you want to get disability insurance or life insurance, you should get that before you're tested. So that's something that we kind of counsel people in their early 20s, because most people in their early 20s are not married, they don't have life insurance, they're not thinking about that kind of thing. So we do kind of comment about that. Go ahead.
If the person gets life insurance or that kind of disability insurance, the company cannot say, okay, we can, like after they get the genetic testing,
right.
The company can.
Right. Once you have life insurance, I think you can continue it. It's just they can deny you up front. So that's why we say get it, and that way you'll have it for for forever. Go ahead.
Was that GINA Act, was this law set because there was a precedent?
Great question. There was no precedent, but there was a fear. So genetic testing was around for about 15 years. And it's a very small community, so we were all waiting, like, are we going to hear about an insurance company that drops you based on a BRCA test result? And it never happened. But they wanted to there were individual states that had protection, but the nice thing about this is kind of overall federal protection. So, okay. So I just want to end, I think I'm ending soon, So this is a concept that we're going to talk about in the next hour. In 2007, there was, Time Magazine had their 10 best buzzwords, okay? And there was this concept of someone called a previvor, which is a really interesting group of people that we've never had before, okay? So this is the 20-year-old daughter that I'm talking about, okay? So there is a whole group of individuals now who don't have cancer, okay, but have been told you're at very high risk for cancer, okay? That's kind of a weird thing, right? Just think about if that was you, you know, and someone said you're at 80% risk for breast cancer and 40% risk for ovarian cancer. That's like psychologically a very hard concept. And in the first 15 years of genetic testing, remember what I told you, we tested people who had cancer, okay? So if I test a 45-year-old who has breast cancer and then I tell them that they're positive, one, they're usually reassured because they know why they got their cancer. Two, they say, oh, I definitely want to have my ovaries out because I don't want to have ovarian cancer. And for them, it's a bit of a closure, okay? They know why they got their cancer. They're going to be proactive about not getting a second cancer. But for their daughters who test positive, it's not a closure. It's like it's opening a can of worms. And so we have a whole generation of people now who are at increased risk for cancer, who's never had cancer before. And as a doctor, you know, it's a very different, like how you take care of them is very, very different. It's just a very interesting, we're going to see it more and more in the future where we have this whole kind of generation of people. And it's important for us to figure out, you know, are we doing them a favor? Okay, and what are the challenges inherent in this concept? And so we're going to talk, I'm not going to, but basically we're going to talk about management in the next hour. Let's see. Okay, I'm going to just end on this. Yeah, let me just end on this. So some people ask me, is there any way for the future generations to not have it? And there is. And so there's something called pre-implantation genetic diagnosis. Okay, and so basically it's not commonly used, but it's something that we actually will tell people about if they ask. So basically, what you can do is when there are embryos, so you have to have in vitro fertilization, okay, so you have to have embryos, and you can actually, when the embryos are at a very early stage, you can take one of the cells of the embryos and check it, because remember, you're only having to check for that specific gene, okay? So we wouldn't take an embryo and say, oh, we want to see if they do the whole, you know, sequence the whole gene. But if there is a specific mutation in a family, you can take a cell from that embryo and test it for that specific mistake. And if you had 6 embryos, you could actually choose to put back the embryos that don't have that gene, okay? All I'm saying is that it's possible to do it. It is controversial, and the reason that it's controversial is because not everybody who has this gene is going to get cancer, right? So if I have really good screening and really good prevention, okay, there is not necessarily a reason to do that, okay? There are syndromes, maybe like Li-Fraumeni or other syndromes where it's 100% chance of getting cancer. And in those, maybe you could justify this a little bit more. But in your lifetime, when you practice or do research, this is going to be, you know, continue to be an issue. And so I think it's important to talk about it. The other thing is, some people will say, well, gosh, I have the gene, and I would be so sad if my mother didn't have me, right? So there's a lot of kind of psychological issues with this. But I just wanted you to know about it because I think it's something that in the future that you'll hear about. So at MD Anderson, we're really focused on this effort because we are trying to cure the individual of cancer, okay, but we actually want to expand that out and not just focus on the individual, okay, but focus on those families as well. So let's take a break. It's about 8:22. Maybe we can take a break for 15 minutes, and then we'll come back and talk specifically about that one syndrome. Okay, let me start by giving you a preview. So I'm going to spend the next hour and a bit talking about hereditary breast ovarian cancer syndrome. okay? And this is the genes BRCA1 and BRCA2. And then this afternoon, Dr. Broadus is going to talk about Lynch syndrome and uterine or endometrial cancer. We kind of use those terms interchangeably. And Dr. Cruz is going to talk about Lynch syndrome as it relates to colon cancer and other colon cancer syndromes, okay? Tomorrow morning, Molly Daniels is our genetic counselor that works at MD Anderson, and she's going to talk about what she does, okay? She's going to talk about what a genetic counselor does, and then she's going to go through about 6 or 7 cases that she's seen as a genetic counselor. So you guys are going to look at pedigrees and then talk about, you know, what you notice in the pedigrees and kind of start to solve the mysteries of cases that we see at MD Anderson. And then in the afternoon, Sherry, what's the name of the breast surgeon who works here? Okay, she's going to talk about the management. I'm going to touch on it a little bit, but she's going to go into much more depth about breast cancer management, okay, for these very high-risk individuals. Okay, so for all of those people who are interested in medicine, we're going to do a lot of kind of, you know, real-world patient management. Okay, so we're going to talk about hereditary breast and ovarian cancer. We're going to talk about the genes themselves. We're going to talk about the inheritance pattern. We're going to talk about the risks involved. We're going to talk about how we do risk assessment, and we're going to talk about management, as well as genetic testing. Okay, so this is kind of similar to that graph that the thing I showed you before. So ovarian cancer is pretty straightforward. About 10%, if not a little bit more, of all ovarian cancers are due to BRCA1 and BRCA2. Okay, the thing to remember is that 90%, okay, are unknown why we get them. Okay, for breast cancer, it's more complicated. Okay, that's why I'm happy I'm not a breast cancer person. It's complicated. Okay, about 5 to 10% are due to BRCA1 and BRCA2. Okay. There's other genes, Li-Fraumeni, Cowden syndrome, okay, all of those can give breast cancer. And then there's about 15 to 20% that we call familial. I think this is a terrible name because most people, when they say familial, they think inherited, right? But that's not what we mean here. It means that basically there's some other cause. Okay, maybe there's some family history. So sometimes we'll see the pedigrees where you see a lot of people in the family, but they're all in their 70s. Okay, so this is what we're going to be talking. We're going to talk about this part of the pie today. But my point with breast cancer is it's very complicated, and there are people who have pedigrees that are a little bit concerning, where you can't actually find the gene, but you think that something else is going on. Okay. Okay, so what are breast cancer risk factors? Okay, so this is kind of one thing I want to point out. So general population risk right now is about 1 in 8. Okay, for all of us in the room, okay, our risk is about 12% in our lifetime. That's pretty high. Okay, and the median age of diagnosis is 61. Okay, so that's why when I say that when you hear about a 30-year-old or a 40-year-old with breast cancer, that's like 2 standard deviations away from 61 years of age. Okay, so what are the risk factors for breast cancer? Older age. Remember I talked about that in general, all cancers occur at an older age because that's when all the mistakes in the DNA start to accumulate. Okay, family history is what we talk about today. Sometimes some benign breast conditions can increase your risk. If you have your periods at a young age and menopause at a late age, if you don't have kids, that increases your risk for breast cancer. Radiation, so a lot of young children who had Hodgkin's disease had radiation, okay, when they're young. And if they're women, that radiation actually increases their risk for breast cancer. Hormone replacement, alcohol use, and maybe high-fat diet. And what can protect you? Having later age at periods, okay, early menopause, early pregnancy, and breastfeeding. Those are general things. Ovarian cancer, going back here, what's the general population for ovarian cancer? Extremely low, okay, 1.5%. So ovarian cancer, even though you hear about it, is not very common, okay? So my risk for ovarian cancer in my lifetime is only 1.5%, okay? Median age is about 63 years, okay? So when you hear about someone who has ovarian cancer in their 40s, again, that's like 2 standard deviations over. That's unusual. What are the risk factors? And this is generally what the risk factors, okay? Not for the inherited kind, but generally what the risk factors. Older age, history of, this is that family history that we talk about. These are other things. These are all questions. You know, none of these are things. But what can protect you? This is, I always like to tell people about this. Having kids protects you from ovarian cancer. Oral contraceptive use, okay? If you're on the pill for even a year, but the best is for 5 years, you decrease your risk for ovarian cancer by 50%. You cut your risk in half, okay? Tying your tubes and breastfeeding are also good things to protect against ovarian cancer. Okay, let's talk about the genes. Yeah?
Why does oral contraceptive use protect against?
Good question. We don't know for sure, but we think it's because ovarian cancer, we think it develops by having repeated ovulation. Okay, it's like breakage and repair, okay? And so we think that when someone ovulates all the time, there's that breakage and repair, and that's when the mutations can develop, okay? When someone's on the oral contraceptive, you don't ovulate. It's like you put everything in a dormant state. And so by having kids, also you don't ovulate. So by not having so much activity, we think that that protects your ovaries, okay?
Polycystic polycystic can increase the risk for ovarian cancer?
There is some association. There's also association with uterine cancer and polycystic ovarian syndrome. Yeah. You know who's at very high risk for ovarian cancer are nuns, okay? And the reason is because nuns, they don't go on the birth control pill and they don't have kids. So from the time that they're 13 till the time that they're 55, they are ovulating every month. And so we think that because we see a lot of ovarian cancer in nuns, that is kind of a clue that it's this concept of never stopping ovulation. Okay, this is my patient here. Okay, she's 40 years old and she comes to me and says, I'm worried about cancer. My mother had breast cancer, okay? And my aunt had ovarian cancer, and my cousin had ovarian cancer. And so what we do is exactly what you guys did. We sit down and we draw this out, and we say, oh, this is interesting. You know, there's no cancer in either your grandmother or your grandfather. But then we say, oh, my grandfather's sister, okay, had ovarian cancer. So this is a classic example of paternal transmission, right? 50-50 chance for each of them. Sometimes none of the kids get it, sometimes all of them. It's each independent. Each person's independent. Okay, so obviously this person's worried. Okay. Do you guys know who this is? You're probably too young, which is so sad for me. This is Gilda Radner. Gilda Radner was kind of one of the early comedians on Saturday Night Live. If you haven't seen her, you don't know her, get on the internet. She's really funny. This is her family history, okay? So she was diagnosed with ovarian cancer at the age of 40, okay? And this is her family history, so much cancer. And so we're so sad because she was a phenomenal entertainer, and this was a preventable cancer, okay? So nowadays, if her cousins had gotten ovarian cancer and had tested positive, she could have had her ovaries out and still been alive, okay? So, same thing here. This is a type of ovarian cancer patient that I will see all the time. Young age, she's 49 years old, and then she comes for her very first visit to talk about ovarian cancer treatment, and we get her family history. She said, oh, my mother had breast cancer at 52, my sister had breast cancer at 49. Very, very likely that she has a BRCA mutation, okay? And then look at all these women that can be helped by this information. If she tests positive, okay, then we can test all these other people, okay? And if they're positive, it's sad, right? As if you're a mother and you know that you've passed something on to your daughter, it's sad. But, okay, you can be proactive about preventing the cancer. She has it whether she knows or not. So better to know, and then you can actually do something about it. And then there's people who, and then each child has a 50-50 chance. This one tests negative. Then with all this cancer, okay, she knows that she doesn't. Interestingly, there's a lot of guilt that can happen when sisters test and one is positive and one is negative. There can be a lot of guilt in the person who's negative. So there's a lot of psychological issues that can come up through genetic testing that we're just learning about. Okay? So let's talk about the genes themselves, okay? They're big genes, okay? BRCA1 is on chromosome 17, okay? And there's over 5,000 nucleotides. Okay, that's why I call it a novel. You're looking for a spelling mistake in a novel. BRCA2 is even bigger. It's on chromosome 13, and there's 10,000 nucleotides. And this is in the coding region. Remember, there's introns and there's exons. So this is just the exons, okay? So we don't really look at the introns, okay? We look at the exons, and we look at the splice sites, okay? The splice sites are the areas in the introns, because sometimes there can be splice site abnormalities that actually cause the gene and the protein to be very small, okay? 81 kilobase genomic DNA, 84 kilobases. It'd be nice if the mutations were always in the same place, but they're not, okay? There's been over 1,200 different mutations that have been reported throughout BRCA1, and there's been about 1,300 in BRCA2. So that's why it's expensive, because you have to look at every single base pair, okay? You can't, there are some, I don't know if earlier in the week if they talked about hotspot mutations. So there's some KRAS, you know, there's some mutations in tumors. We're not talking about germline, but in tumors that are hotspot mutations. Okay, so what's the actual risk? Okay, and this is important. So if you have the gene, and this is what your risk of cancer is up until the age of 70, okay? And if you have the gene, this is your risk for ovarian cancer. So remember what I said about what's your risk for breast cancer is about 12% by age 70. Okay, here, your risk is, we actually quote 80%, that's the upper limit of normal, but it's probably between 50 to 80%. So think about 11% or 12% versus 80%, right? Wouldn't you think about doing something fairly dramatic if you're at 80% risk? And then ovarian cancer is even scarier because there's no screening for ovarian cancer. So remember what I said, general population is about 1%, okay? But then if you have this gene, you're at 40% risk, okay? So 1% and 40% for a cancer that's very lethal, that's a big difference. I want to talk for a minute about how we get these numbers. So over the last 20 years, we've kind of refined it. Initially, all the numbers were based on the families, okay, that had a lot of cancer. So if you try to calculate out what risk is in families that have a lot of cancer, you're going to have a much higher number, okay? But now, after 15 years have passed, we've identified a lot of families that have the gene that might not have as much cancer. So our estimates have kind of fallen a little bit. So instead of an 80% risk, it's fallen, but it's still high, right? 50 to 60% is still high compared to 12%. But our estimates are getting better because we're broadening out who we look at. And that was BRCA1, and this is BRCA2. So BRCA2, they're called the same things, but they're they're different genes. So breast cancer risk, okay, is still high, maybe up to about 50%, maybe higher. But ovarian cancer risk is a little bit lower. So instead of 40%, it's 15%. But still, compared to 1%, 15% is still high, and it's still for a lethal cancer. Okay, so these genes, they're important genes, and we don't know all the functions, but here are some of them, okay? So it's a tumor suppressor gene. It's likely involved in DNA repair. These are very important genes, Okay, so if you lose one copy of the gene, it's okay because you have the other copy that's working, okay? But if you lose the other copy, then you don't make the protein anymore. So if this protein is important for DNA repair, okay, that means that when you have a mistake, you have a whole series of proteins in your little cell whose only job it is to fix mistakes. So if you knock out, if you've inherited one bad copy and you knock out your other copy of a very important gene that repairs DNA, you're going to have all these mistakes in your DNA. And then if it happens to occur in P53 or EGFR or another important gene, that's how cancer develops. You know, one question is, why does cancer only develop in the breast and the ovary, right? If you have this mistake in every gene in every cell in your body, why is it only breast and ovary? Or why is Lynch only uterus and colon? I'd say that's your generation's job. I know we've got graduate students in the room. That's your job to figure it out. It's kind of an interesting question, right? Theoretically, you should be developing cancers in multiple things. So for Lynch syndrome that you'll hear about this afternoon, that is definitely a DNA repair gene mistake. And so even though we see it more frequently in colon and uterine cancer, it can be actually anywhere. You know, we can see ureteral cancer, brain tumors, skin cancers, small bowel cancers. So there's and that makes sense, right? It's a general DNA repair mistake, and so we think that BRCA is important for DNA damage recognition and repair, for transcriptional regulation of gene expression, chromatin remodeling, and cell cycle checkpoints. So these are the bottom line is it's an important gene. If you don't have the gene, you're missing the protein, things are going to go awry. Okay, this is that concept again about why a gene can cause such big problems. Okay, so let's say normally this is your BRCA gene. It's not the gene that's doing anything, it's the protein that's made from it, right? That's an important concept. So, you know, this is your BRCA1 gene and you make a functional BRCA1 protein. If you have a mistake, okay, and suddenly a T becomes an A or a C becomes a T, okay, it can change the amino acid, and it may be that that's where it's a binding site for another protein, okay, or it can actually cause a stop, and so your protein is either shorter than it should be, okay, or it's not functioning, okay. So when we talk about gene mistakes, the reason that it's ultimately important is because the protein that's made from it is no longer functional. Okay, and then tumor suppressor gene, this is kind of things that I talked about this morning, remember? So sporadic cancer, you've got two normal genes, and then when you have two mutated tumor suppressor genes, you develop the tumor. In hereditary cancer, you're born with one bad one, and so it happens at a much earlier age. Okay, how common are these mutations? Okay, so the reason that I'm pretty confident that nobody in this room has it is that it occurs in about 1 in 500 to 1 in 800 individuals. So if I were in a room where there were 5,000 people, I'd say, ooh, probably about 5 of you have this, okay, or a little bit more than 5. But in this room where there's maybe, I don't know, 40 or 50 people, it's not likely that there's going to be someone or even more than one. Okay. Remember that so if I have a room of 100 people, I'm not going to be able to find somebody with this mutation. Okay. But remember the pie chart that I said about 10% of ovarian cancer patients have it. So why do we focus our testing on the people who have cancer? Well, 1 in 10 of my patients is going to have it, okay? Whereas in people who don't have cancer, it's 1 in 500. So that's why if I want to use my genetic testing money appropriately, it's better for me to focus on the people who have cancer, okay? Because I'm enriching a population where I can find that mutation, okay? So another thing to let you know is that there are certain populations where the mutations are more frequent, okay? In the US, we know that Ashkenazi Jewish ancestors, instead of 1 in 500, it's 1 in 1 in 40. So why is that? Okay, the reason why is because any population that has been closed off for a period of time, if there's a mutation, it's going to become more common. Okay, so there are multiple different ones. So that concept of a founder, we call it a founder mutation or a founder effect. So another place is Greenland. Okay, Newfoundland, an island off of Canada, has a lot of Lynch syndrome. Okay, and anytime, the idea is that you have someone who developed that mutation, okay, and because there's not intermarriage, it ends up so that generations later it's more frequent, okay, than in a population where there's lots of intermarriage. Okay, so that's why in the Jewish population, okay, that there are certain mutations. So there's 3 different ones. There's the 185 position. There's missing an AG. There's this position where there's an extra C that got inserted. And then BRCA2, there's a deletion of a T at this site. Okay, this occurs about 1% of the population of Jewish individuals. This is about 0.15, so not very common, and this is 1.5. So all in all, okay, instead of 1 in 500, it occurs in 1 in 40. Okay, and so in the US, that's important to know. What are some other populations with founder mutations? It's actually any populations that's been closed for a period of time. Okay, so Iceland has theirs, Finnish, Norwegian, Swedish, Dutch, French Canadians, Hungarians, Poles. So any population that for a period of time was isolated. So how can that help me as a doctor? The reason it's helpful is that, especially in my practice, we don't have a lot of Jewish individuals, but in New York and LA, there's more individuals who are Jewish there. And if you see a woman with ovarian cancer, remember the pie, right? 10% of ovarian cancers are due to a BRCA mutation. But if it's Jewish individuals who have ovarian cancer, I'm not talking about all Jewish people, but Jewish people with ovarian cancer, that piece of the pie becomes 40%. Okay, so if you're a woman who's Jewish and you have ovarian cancer and you're sitting in front of me, about 40% of the time I'm going to be able to find a mutation. So I definitely want to do testing on you. I mean, now we're doing testing on all ovarian cancer patients, but before it would be, instead of 10% of the time, we'd be positive about 40%. So that's why it's important for me from a clinical standpoint. The other reason that it's important is that instead of doing the expensive testing for every gene, what we do is we start by just doing the 3 founder mutations because it's cheaper, okay, and it's more likely to be positive. So in a Jewish population with ovarian cancer, I'll start by just doing those 3 founder mutations, and then if that's negative and I'm still concerned, I will do the whole gene. But it's a way to be a little bit more targeted and focused when you're doing the genetic testing. Okay, so what are my red flags for these mutations? Multiple family members with breast and ovarian cancer. So I've looked at multiple people's pedigrees this morning, and no one I saw makes me worried, okay? So there's nobody here where I say, ooh, I'm worried about that. Early onset of breast cancer, less than 50 years. Okay, ovarian, fallopian tube, primary peritoneal cancer. Someone asked about male breast cancer. Not very common, but if I see it, I worry a little bit about BRCA1 and 2. Multiple primary cancers in the same individual, we talked about that, right? Has someone had 2 breast cancers, 2 primary breast cancers? Sometimes when you have breast cancer, we'll just do a lumpectomy, okay, and not do a full mastectomy. And then 5 years later, did they develop another breast cancer? We call it a separate primary. Did someone in the same person have breast and ovarian cancer? Jewish ancestry. Triple negative breast cancer is another type of breast cancer that is particularly associated with BRCA1 and 2, and then male breast cancer. And then just a reminder that BRCA1 and BRCA2 are autosomal dominant. It's autosomal dominant, but it's incomplete penetrance, okay? So that means that, let's say the father has the mistake, okay? And so, right, the mother's doesn't have a mistake, so from the mother's side, it's no problem. But each child has a 50-50 chance of getting this one from their dad or this one from the dad. It doesn't mean that if you have 4 kids, that 2 for sure will be positive and 2 for sure will be negative. Each child is an independent event, but by chance, it should work out that it's about half of them, okay? So here we have an affected son, okay, and an affected daughter, but when it comes to BRCA, it's unlikely the son is going to get cancer, okay? So this son may be a carrier, and it's important, not so much important for him, but it's important if he has 4 daughters, it's important, right? And then this daughter is at increased risk. Go ahead.
That is going to be the same for all types of cancer?
So, no. So your question is, if you had a dad with lung cancer, is there a 50-50 chance? No. We're only, remember that 90% of cancer is sporadic. So we're not talking at all about sporadic cancer. We're just talking about inherited cancer. So we're talking about a group of families that are unusual, okay? We don't see it very often. When we see it, it's important to recognize it, but I think it's really important for you all to understand that the majority of cancers in your family or in your friends, okay, are sporadic cancers. But it's a great question. Okay. So, and this is what I talked about before, okay, causes of hereditary susceptibility to breast cancer, okay. The majority of families that have breast and ovarian cancer, okay, the majority are BRCA1 and BRCA2, okay. With breast cancer only, if you only have breast cancer, BRCA1 and BRCA2 accounts for for the majority of these, but there's other genes as well. P53, P10, Cowden's, other syndromes. Okay, these are the other syndromes, okay, other hereditary breast cancer syndromes. Li-Fraumeni, that's what you heard about with Dr. Strong and Dr. Lozano. It's a germline mutation in P53. This is like a bummer, I have to say, if you have this, because this is such an important gene that if you're born with one copy not working, you know, you develop lots early onset childhood cancers, multiple primary cancers, and some rare cancers, okay? Cowden's is a P10 gene. These are all tumor suppressor genes in which breast cancer tends to be prominent. Peutz-Jeghers disease, it can be breast cancer, but also some GI cancers, and ATM. So as you all go through medical school and graduate school, you'll study these in terms of how important they are to the cell, okay? But the important thing from a clinical disease standpoint, and an inherited cancer standpoint, is if you're born with a mistake in these very important genes, you're at much higher risk for developing cancer at a younger age. And so this is just the same thing, saying 10% of ovarian cancers. And ovarian cancer, just to mention in anticipation for this afternoon, the majority of them are BRCA1 and BRCA2, but there are some ovarian cancers that are due to Lynch syndrome. Okay, this is what we talked about this morning, right? Factors to consider: personal risk factors for cancer, age of onset, histology. This is becoming more and more important. So it turns out that it's what we call a genotype and phenotype association, okay? So when you have a mistake in a certain kind of gene, you develop a certain kind of ovarian cancer. So it's not just ovarian cancer, but it's a high-grade serous ovarian cancer, okay? And it's not just a breast cancer, but it's a triple negative, ER negative, PR negative, HER2 negative breast cancer. So that's an interesting, again, that's a mystery for the PhD students in the room to figure out, okay? Why is it that when you have a gene mistake, it turns out that they have a very specific kind of breast or ovarian cancer. Okay, so this is that histology thing. So for BRCA1, okay, this tends to be triple negative, ER negative, PR negative, HER2 negative, and it tends to be ER negative too. These are very aggressive cancers that happen in young people, okay, so they're rare. And then we started to see, you can imagine how this whole thing started, is that, ooh, we see a lot of young people, they have this rare cancer, and it turns out they have BRCA mutations, and then we put it all together. That's how clinical research works. For BRCA2, compared to BRCA1, it tends to be more ER-PR positive, and it tends to be later age of onset. Ovarian cancer, it tends to be high-grade serous histology, okay? And so that's where if you were a genetic counselor and you were drawing a pedigree and your patient said, oh, my aunt had ovarian cancer, the genetic counselor would say, go get the pathology report. Because when we get the pathology report and we look at the ovarian cancer, there's lots of different kinds of ovarian cancer. If you had a germ cell tumor, if you had a stromal cell tumor, that's not the kind that's associated with this mutation. So you can very easily say, you know what, you don't have to worry about this, because the kind of ovarian cancer that your aunt had is not the inherited kind, okay? And these are the risks that we talked about already, right? Breast cancer risk is somewhere between 50 to 85%. BRCA2 is somewhere between 50 to 85%. How does this make a difference? The breast surgeon is going to talk to you tomorrow. If I know when I have a 45-year-old woman sitting in front of me that they have breast cancer and they have a mutation, what am I going to recommend for them surgically? Am I going to recommend a lumpectomy, or am I going to recommend a bilateral mastectomy? Okay, I'm going to say that again. If you're a breast surgeon and you have a 45-year-old woman in front of you, okay, and you don't know what her BRCA mutation status is, in general, we want to do less, right? We want to just do a lumpectomy. But if you knew that she had a BRCA mutation and her risk for developing a second cancer is 40 to 60%, wouldn't you say, I recommend a bilateral mastectomy? Okay, so that's where having this information makes a difference in terms of surgical decision making. Okay, so that's why before we said, oh, this will help your daughters, this will help your relatives, we'll do it when you come back. Okay, but now we realize this information, you need to know it right up front when you're diagnosed. Okay. Risk of ovarian cancer, about 45%. And this is about 20, so it's a little bit lower for BRCA2. Male breast cancer, it's probably a little bit increased, but here it's about 6 to 7% lifetime risk. Maybe prostate cancer is up a little bit, but the problem is prostate cancer is so high. And pancreatic cancer probably is elevated, but 2 to 3%, and we don't have any good screening for prostate cancer. But again, remember that concept, every cell in your body has BRCA. Right? So if you have a mutation in every cell of your body, you can imagine, even though these cancers are more common, you can develop cancer in other places as well. The question is why, and like I said, that's for your generation to figure out. Okay, any questions so far? Go ahead.
Question. Is it possible to be a double negative, but not both BRCA1 and 2 And what's the risk?
Good question. Double negative for BRCA1 is lethal, which means the embryo will not develop. So you can't have 2 knockouts of BRCA1 as an embryo and develop. But yeah, we have people who have a BRCA1 and a BRCA2 mutations. That's like winning the genetic lottery. That's a disaster. I mean, it's not a disaster, but I have a patient who has that, and it's weird, but you can. We don't know. I'll let you know. Ask me in 20 years. We don't know. And also, like, how did those people find each other? You know what I mean? And 1 in 500, it's like, how did they find each other? So, go ahead.
What is PR negative in relation to breast cancer?
Progesterone receptor negative and estrogen receptor negative. And the reason that they're a little bit more aggressive is that when they're ER positive and PR positive, we can treat them with anti-estrogen treatments. But if they're ER negative, they don't respond as well to that. Okay, back to genetic testing. So we're going to talk about how this works. So remember I told you that we always want to test the person with cancer first. Okay, and then if these kids were age 5 and 7, we wouldn't test them, right? And the reason we wouldn't test them is because it's not going to, their risk for cancer is not until, you know, into the 30s and 40s. So there's no reason to test them. But in their 28 and 24, that's when we start talking about testing, right? And how do they use this? Okay, so why are they helpful? Okay, it helps with the precision of risk. So remember, if we didn't have genetic testing, then both of the daughters would just have to worry, right? If you can't do genetic testing, then every female relative you have to worry about, right? That's bad. You don't want to do some kind of dramatic surgical procedure if they're not at risk, okay? Or you don't want to put them into menopause by removing their ovaries at 40, okay, if they're not at risk. So in some ways, a negative result is even more powerful for these families, okay? Because it means that you don't have to do these dramatic things. Okay, so if they test positive, we counsel them for screening and prevention. If they test negative, okay, we always say you're at general population risk. Not zero risk, but general population risk. Okay, so how's it information important for the patient? Remember surgical decision making? We just talked about that, okay, how that's important. And then I told you before that for ovarian cancer, they actually do better. So it's kind of like when I disclose results to an ovarian cancer patient, the bad news is you're positive. The good news is your survival is going to be better, okay? It's a very interesting thing, and we're trying to figure out why that is. And then also there's new drugs that are specifically useful if you're BRCA positive. Okay, what's the cost? These are a little bit old, but to do the full analysis, now it's about $4,000, okay? If you're Jewish, why do we start with this? It's much cheaper, right? $575 just to look for those 3-point mutations. Once you find the result in someone who has, so let's say we have a positive result in the family, the mother is positive, to test the daughters and the nieces and the sister, it's only $400, okay? You don't have to do the full sequencing anymore. You just have to look for that spelling mistake. Okay, you just have to go to the same page, the right paragraph, the second sentence, that's where the spelling mistake is. It's a much more targeted thing. And then there's also something called, and I think Molly's going to talk about this. I'm not going to go into that. It's just a different, looking for, you can actually have huge areas of the gene that get deleted, not just a single mutation, but huge areas of the gene. And so when you sequence one by one, it's kind of like looking at the trees. You don't see the fact that there's a whole part of the forest that's missing. And so there are families that are missing huge parts of the gene. And by doing the sequencing, we didn't pick it up. And so that's why we found there were families that we feel like, oh, we should have a mutation, but we couldn't find it. And then we realized it's because they had huge pieces of their gene that are missing. We talked about this already. We talked about this, right? Positive, negative, or variant. This is what it actually looks like when you get the result back. There's one company that has a patent on the testing called Myriad. And so when we send the blood, okay, you can either send blood or you can actually send a smear from the you don't have to send tumor, right? We're not testing the tumor, we're testing the person, okay? It'll say positive for a mutation, and here it'll show you that it's they do BRCA1 and BRCA2, and here's the specific mutation. 8141, so it's at that nucleotide, there's a deletion. Okay, and then we talked about this before, right? A positive test result, what it means and how it can be helpful. We always provide patient education materials, because you can imagine when I'm telling you that you're positive, like your whole mind kind of goes blank. And so we always want to give people material so that they can go home and read more about it. We always provide a letter, okay, so that they can give the letter to their family members, to give to their doctors, okay, because it's kind of complicated to explain to your relatives. And if you have 7 cousins, it's just easier to send a letter to them, okay? So we always provide that letter. We actually have clinics specifically for high-risk patients, okay? And then if you want to, just for fun, get on the website. There's a website called Force or Facing Our Risk. And you can just Google Force. You can Google Force and breast cancer. And basically, it's a site for people to go to where there are other people who have the same thing. And they say, you know, what do you think about getting a bilateral mastectomy at age 35 or 32? You know, oh, I had it and I'm miserable, or oh, I've had it and I'm so happy. You know, it's an online community for people. And this is just another one. They're both very, very good. This is a single site analysis, so basically saying that this is the daughter testing for that one specific mutation, and it's negative. So the daughter tests for this, as long as the family tree is obvious and it really looks like it's coming from the mother, you don't have to do full sequencing. But if sometimes what we see is that we see the dad side and the mom side both are concerning. So let's say that the mom has a mutation and you test just for that mutation and it's negative. Sometimes we'll actually either, if the dad side is concerning, we say, even though this is negative, we want to reflex and go ahead and do the full mutation testing, just in case she got it from her dad. This is our best result. We always do a happy dance when we see this. It's when we know that the mutation in the mother, okay, and we test the daughter, and they're a true negative, okay? We're very happy when that happens. Then they say, can it skip a generation? No, it can't skip a generation, okay? So if that daughter's negative, her children will never inherit it.
I was just wondering, has gene therapy been tried on?
That's a great question. No, but that would be kind of the outside of the box thing to think about, right? So, okay. One question, are all negative test results reassuring? Okay, the answer to this is no, they're not all reassuring. If you have a positive result in the family, then a negative result is helpful. But if you don't have a positive result in your family, okay, it may be that that there's some other cause that we just don't know, BRCA 5, 6, or 7, that we haven't discovered yet. So you can't be completely reassured. Go ahead.
And that happened with the Jewish population, like if you screen for those three mutations and you don't find any, but the person has cancer, so you would have to do the whole genome sequencing.
Right, right, right. And you do the whole genome sequencing, you might find something, but you may do the whole genome sequencing and still not find something when it's still a really concerning family history. So this comes up when your family history looks really bad, and you do the single site, and you do the multi-site, and you do the comprehensive, and you still can't find anything, then we're just frustrated, and we say, how do we manage those people? So from my standpoint, I'm a doctor, I have to work with incomplete information. The easy patients are the positives. You know what to do for them. They're positive, they're increased risk for ovarian cancer. We want to surgically remove your ovaries by the time you're in your mid-40s. That's easy. The hard ones are, oh my gosh, your family history looks bad. We can't find a mutation. Do I take your ovaries out? Do I not? Do I take your breasts off? Do I not? Those are the harder patients, to deal with. And that's what this inconclusive negative means. Okay. And then this is that same concept again. You're going to hear it a lot today, and you're going to hear it more tomorrow. You always want to start it, okay, with someone who has cancer. What happens in those families where it's so compelling and you can't find something? We actually, sometimes we do more testing, and Maya's going to talk about that tomorrow, okay? The other thing is we will bank their DNA, because most of our cancer patients will die, okay? And so what we'll do is we'll say, you know what, we can't find something, but we know something's going on in your family, so it's not very expensive. You can just actually take some of your DNA and just bank it, because we're discovering new genes all the time. So we may discover BRCA 4, 5, and 6 10 years from now. And if we have your DNA, it can help your family, it can help your daughters. So then we'll recommend that you bank your DNA.
So that's my question. When you say inconclusive negative or negative,
Yeah.
you're only testing for BRCA1 and BRCA2.
Right.
But if the human genome is already genotyped,
Yeah.
When you test the comprehensive, you
Yeah.
don't know if there's a mutation that you just don't know what.
Correct.
I guess my question is, can you know if there's a mutation that you just don't know what the gene does? But do you know if you do the comprehensive that there's a mutation?
What we do know is that as it becomes cheaper to do it, Like there are now some companies that are going to do more than just BRCA1 and 2 because now it's getting cheaper. And so there are companies that are going to do, especially for breast cancer, they're going to do BRCA1, BRCA2, P10, P53, all of these, and you're going to get more information back. The problem is, even though you're going to get potentially more information, you're going to get more noise too, because you're going to find out a lot of these mistakes. And it's like, is that a meaningful mistake or is that just a change that doesn't mean anything? So you can end up driving patients crazy too. So, but that'll happen in your lifetime. So in your lifetime, it's not going to just be testing BRCA1 and 2. You're going to be getting a whole, it's called next generation sequencing. Okay, so you're going to be getting data from next generation sequencing and you're going to have to interpret it. So, and interpret it with the patients. Okay, okay, this is just showing that this patient, okay, here's the problem is that she doesn't have cancer, okay, but many of her relatives are dead. And so sometimes we will test someone who doesn't have cancer and they test negative. So the question is, should I reassure this person? Okay, well, when they test negative and it's not a true negative, it's like an inconclusive negative, what we have to say is, you know what, we're not really reassured because you have a lot of cancer in your family. So let's just base your management, okay, on your family history. Okay, so what I'll tell her is I'll say, you know what, I'm still a little bit worried about you. Let's just be cautious and screen you. Okay, so what happens is that in 2007, okay, that's when we added this large the large deletion testing, and it turned out that they found a mutation. Okay, so if we had said to this person, no worries, don't worry about anything, you tested negative, okay, she could have developed cancer if she weren't getting screened. Okay, but then my point is that things develop over time. Okay, that we're not perfect in our technology now, and so in 2007, the nice thing is that we keep records of all these families. So when this new technology comes out, we send a letter, okay, to all of these families that tested negative, and we say, there's new technology now. You might want to come back in to get tested. Okay. So now she tests positive, and now she's young enough, she hasn't developed cancer, but now we know absolutely that she's positive. So then we're going to recommend that she undergo she probably was getting intense screening anyway, but she might want to move towards having the surgeries. Okay, this is that variant thing, we talked about the variants. Okay, so this is just showing you how we do this on a day-to-day basis, okay? We start with the cancer patient, okay? We do a risk assessment with our genetic counselors. We do genetic testing. And if they test positive, that means that for the patient, we're going to do certain different things. And then for the family members, we're going to do predictive testing, and if they test positive. Okay, so this has implications not just for the patient, okay, but also for the family member. This was a study that we did, that one of my fellows did. And it basically showed that if you take a large group of people with ovarian cancer who have a mutation, and a large group of ovarian cancer patients who don't have a mutation, that the survival is much better, okay? So the survival advantage is much better. And we also learned that, remember we're talking about germline, and we also have somatic, the tumor changes. So there are people who have germline BRCA mutations of ovarian cancer, and then there's ovarian cancers themselves that have mistakes in the BRCA gene, okay? So those are called somatic BRCA changes. And it may be that the survival advantage is for people who have germline BRCA and who also have the somatic BRCA, okay? And then this is the PARP inhibitors. Remember I was telling you that there's some drugs that are specifically good for people who have BRCA-associated ovarian cancer. Okay, so how does this work? Okay, so PARP is a protein, okay, that's necessary to fix mistakes. Okay, a lot of these proteins are important for DNA repair. Okay, if you use a drug that inhibits this, okay, then what's going to happen is you're going to have more mistakes in your DNA. Okay, if you if you normally have no problems with your BRCA, okay, you're going to have survival. But if you have deficiency in your BRCA, you're going to have more cell death. So the idea is that a PARP inhibitor is going to be better for people who have BRCA-associated ovarian cancers. And that's the concept. So over your lifetime, you're going to hear more and more about drugs that specifically target people who have BRCA-associated cancers. And this is just one trial, okay, that showed that if you look at this higher dose here, these were all ovarian cancer patients that had BRCA mutations, and basically showing that these people tend to do very, very badly, and maybe the response rate is usually in the 5 to 10% range. And here we saw a 20% response rate, and that's because these people had BRCA mutations. Okay, so we're going to end in the last 20 minutes talking about what happens to the daughters, okay? How do we counsel the daughters? What do we tell them to do? So one important thing that we do is we need to provide them with information that's going to be helpful for them to make the decisions. So one of the big questions that people say is, okay, you told me you have to remove my ovaries, okay, to prevent ovarian cancer. Do I have to do that when I'm 30, or can I wait till I'm 50? Okay, that makes a big difference, right? If you have to have your ovaries out when you're 30 and you haven't had kids, that's a very sad thing, okay? If you can wait until you're 50, that's good, because not only can you have your kids, but you also don't have to go through menopause early, okay? So knowing the precise as possible age that you are going to develop cancer helps you make good decisions. So I always say it's like, if you know the cliff is here, you want to make the last left turn before you fall off the cliff. The problem is you don't know when that cliff is going to happen. So you're trying to guess, I want to take my ovaries out right before I get cancer, okay? I want to keep them as long as possible so that I can have kids and have ovarian function, but I don't want to wait too long because then I'm going to fall off the cliff, okay? It's hard, but we use these studies, okay, to help us estimate what these risks are. So for example, if I'm 30 years old here, okay, this is current age, what is my risk of developing ovarian cancer, you know, by age 50? It's about 8.7%. What's my risk by age 60? It's about 22%. So, you know, that means that there's a 90% chance that you won't get ovarian cancer. So then you might say, ooh, I'm going to wait a little bit. And you might say, well, I want to kind of have it here when, by 22%, that's pretty high, right? And then after 50, my ovaries aren't really working anyway. So you definitely want to have your ovaries out in the 50s, but what about, you know, can I wait a little bit? So you know, that's how we use these numbers. And it's interesting because everybody sees things differently, right? If your mother died of ovarian cancer, you may say, you know what, I know what this disease is. I don't want to chance it, okay? So I'm willing to lose some of my hormone function earlier because it's so bad to me. If you've never had anyone with ovarian cancer, you may say, well, gosh, 8% chance, you know, that means there's a 92% chance that I'm not going to get it, so I'm willing to wait. So there's a whole body of research around how people make decisions and how they view risk. So for breast cancer, we do increased breast screening, okay? And basically what we do, this is the main thing, is that, do you know when we recommend in the general population that you start mammograms? It's a little controversial, 50 for sure, but sometimes people say 40. But here we're saying at age 25. Okay, so that's a big difference, right? And not just getting mammograms every year, but every 6 months getting a mammogram or an MRI. Okay, so that's pretty intensive screening. And remember that screening is not always perfect. So especially with MRI, you can pick up things that look bad, but you're not sure. So it has a high false positive rate. So that just think about all the worry that this causes. So the good news is you might pick up a cancer early. The bad news is we drive people crazy. So.
Would also having those mammograms and MRI studies and stuff so early, wouldn't it also bring risks with the radiation that you're receiving? And also could it also cause like for a more rapid mutation?
Yeah, that's a great question. And that's definitely a concern that people have. Yep, yep. So is there any way that we can give someone drugs to prevent it? So there is a drug called tamoxifen, and we can reduce the risk of breast cancer in the general population. The problem is that it looks like it's helpful for BRCA2, because remember BRCA2 had more ER-positive breast cancers, but for BRCA1, it doesn't really help it, because BRCA1 tends to have estrogen negative, right, ER negative, PR negative. So we don't have a perfect drug right now that we would recommend that you take to prevent cancer. Okay, surgery, why do we keep going back to surgery? There's a 90 to 95% reduction in risk, okay? That's really, really good, okay? But it's so dramatic. So those are the hard things that people have to think about. How about removing your ovaries? The nice thing about removing your ovaries is you actually decrease your breast cancer risk. Okay, if you have it done before menopause, and that's because you're decreasing your estrogen. So there's advantage there. For ovaries, there's no good screening for ovarian cancer, no proven benefit. We still screen because it's such a terrible disease, but we've never shown that it's beneficial. Okay, go ahead.
No, that's my question. Instead of like removing the ovaries, would you recommend that a woman who's about 35, 40, but she's already had her children, just be put on oral contraceptives?
Yes. Yep, definitely. Because oral contraceptives have such a big risk reduction. The problem is there's still some controversy about whether oral contraceptives may increase breast cancer risk. It probably doesn't, but it may, like at a younger age. So that's why it's like, we can also drive people crazy because it's like, okay, your GYN doctor says take oral contraceptives, and then the breast doctor says don't take oral contraceptives. So we have to work towards kind of coming up with a coordinated plan. And then surgery, right? So for removing the ovaries, I spend a lot of time saying don't worry, you can wait, okay? Wait. We say 35, but I'm pushing it even further. Like 40 is okay with me for BRCA1. Actually, 45 is okay for me for BRCA2. I want to tell people that, you know, have your kids, get married, don't worry about that. And it's very, very good. It works. It's not 100% because there's the lining of the abdomen, and that's the same as the lining of the ovary. And so even though you take the ovaries out, there's still a small risk. So we have to tell people there's about a 1% risk. And then men, what do we tell men? Breast cancer screening, monthly breast exam. We want them to see their doctor every 6 months. And there's a consideration for mammograms. For prostate cancer screening, we offer PSA at 40. But you know, this is still controversial because we're not really sure what to do with this. So in conclusion, 5 to 10% of breast and ovarian cancer is inherited. BRCA1 and 2, they're tumor suppressor genes, and they're responsible for the majority of this. You always want to use family history to determine the likelihood of hereditary cancer. Genetic testing can be very, very powerful. And then you want to base your management on that genetic test result. And I think that is all I have.